Thank you very much. Good morning, ladies and gentlemen. I would like to thank the Society for giving me this opportunity to present our audit. This is an audit about how to investigate, about how well the patients are knowledgeable about their procedure and how well we are documenting. Basically, we want to investigate how well we are adhering to the GMC guidelines in this issue. So why have we done this audit? Because firstly, I'm interested in this subject. Secondly, because I have observed that we tend to neglect this area of our clinical doings. We are too much involved in cutting and operating. We want to get our hands dirty, but we tend to neglect these areas, which shouldn't be neglected. So, and also, it's been recently, over the last few years, a hot topic, really. This area. So I'm using this.
Perfect.
We have started this project. Well, I've tried to do that project in 2014, and so on was dragging on. And 2015, at the beginning, we have started the project, and halfway through the project, we have heard about a court case ruling, a Supreme Court case ruling that was about Montgomery versus Lancashire Health Board. I was made aware of that by Mr. Hamilton himself. Therefore, I looked into that as well. This ruling has changed the emphasis. Basically, it has taken the focus from the clinicians and gave it to the into the corner of the patients. In that sense, the Bolam test is no longer valid. What means now is, for example, if we are thinking about mentioning the risk of permanent pacemaker for aortic valve replacements, do we want to put that on a consent form or not? Some of us may think, okay, I don't usually mention it, and it's enough for this person, for this clinician, to bring about or to ask a responsible body of medical opinion, clinical opinion, to say they wouldn't put that in either. Therefore, that would be okay to leave it out. Now the emphasis has changed. We have to think about the patient, what the patient would like to know. And if we think that the patient, a reasonable person in the patient's position would like to put significance into that risk, we should mention. In translation, that it probably means that all of the possible complications would need to be included in the consent form now. Okay. So how did we go about this audit? We want to look at the two aspects of the consent process. One is the patient's knowledge about their procedure, and we have tested that with face-to-face interviews that took part on the night before the operation, and after they've been seen by all the relevant people, including anesthetists, and they have signed the form. And we have used validated questionnaires that's been developed in the past just for this exact purpose. And the second part of the audit was about documentation, how well we are documenting and how well it's completeness and how good is the accuracy. This is an example of the questionnaire for the coronary bypass grafting. There are 16 questions here, and all of those are derived from the GMC's recommendations on informed consent. We have used a particular scoring system to score each question and the whole questionnaire. So to pass the whole questionnaire, you have to have more than 66% of the total score, and also not fail more than 25% of the questions. So results, first part, the questionnaire, which is about the knowledge of the patient. In aortic valve patients, 93% overall failure rate. That means 93% of the patients failed to know enough about the procedure to be able to give consent. And to note here is the complication. None of the patients knew enough about the complications about the procedure. The further problem areas, only 4 important ones, only 4 more common ones are stated here, disease prognosis, mortality, and anesthetic issues. In Grafts patients, the picture is not as dismal, but still a lot of room for improvement. Complications, again, on the top spot here with pain management, anesthetic issues, and alternative treatment options as further problem areas. And in lobectomies, the failure rate is again the same, around 85%, and again, complications at the top spot. Alternative treatment options, anesthetic issues, and mortality following the top spot with complications. Then we thought that's very depressing, and we wanted something to cheer us up. However, that didn't happen. When we looked at documentation, none of the 52 consent forms were completely filled. And on average, a quarter of the required fields were not filled. And also, on average, only half of the appropriate complications were stated. Therefore, no surprising that the patient didn't know much about complications. And one patient who had signed the consent form had short-time memory loss. So we had to exclude this patient from the questionnaire part. Interesting was here that there was no mention about short-term memory loss in the case notes, and there was no assessment of capacity of this patient to give consent. I'm not arguing that he wasn't able to, but there was no mentioning of it in the notes. So we can conclude that there is plenty of room for improvement in our department, and I doubt, from my experience in all the other departments, that it's much better in other departments. However, this is just my opinion. The level of knowledge of patients are really poor, and if we put the Montgomery ruling into effect here, close to 100% of all of the patients don't know much about the procedure they're going through, and documentation is entirely useless. So, in light of our audit, we would like to recommend that the patients are consented at the first encounter. That would be in the clinics for electives and cardiology wards and for unstable patients. And I have to say, a clinic can really have a lot of information, and that goes to the patient, and they can read through it again and again if they want to at home until the day of procedure. And also to use pre-printed consent forms. I know these do exist, especially in the US. And also, if that's not possible, because some of our consent forms are very flimsy, they cannot go through the printer. We've done that in the past, myself and my colleagues, but we can put it on stickers, certain complications, certain things, and we can put this on the consent forms. Also, it would be nice to develop an audiovisual information tool for patients that's also accessible for them at different points of their process. And we would argue to introduce separate anesthetic consent forms. And I know that in some units in the UK they are doing this already. And I think that would also add and help us with the issues of consent. Thank you very much.